morning friends, welcome again to the series of the continuous cardiac education organized by Unmicrc Institute of Cardiology and Research Center Ahmedabad. Myself Dr. Murugesh Prajapati, and today we are going to discuss about the coronary anatomy. So as you all know, these are the famous paintings Mona Lisa and the Last Supper, which was made by the painter Leonardo da Vinci. The same painter, architecture and engineer has made first diagram of the coronary arterial circulation in early of the 16th century. Then after various studies have been performed to study it thoroughly. So a coronary artery or the arterial branch is any vessel that carry blood supply to the cardiac parenchyma. The word coronary means like a crown. So the coronary arteries lie over the heart in the same fashion like the crown lie over one's head. From anatomic point of view, the coronary arterial circulation is naturally divided into the two main distribution, left and the right. From the standpoint of the surgeon, it is divided into the four parts: left main coronary artery, left anterior descending coronary artery and its branches, left circumflex artery and its branches, and right coronary artery and its branches. The coronary arteries and their major branches are located in the epicardially and the subepicardially. Then it gives branches, the perforating branches, which runs into the myocardium perpendicular to it, and during the contraction of the myocardium, these arteries get compressed and squeezed. So the myocardial circulation or perfusion mainly happen during the diastole of the cardiac cycle phase. The major coronary arteries form a circle and a loop around the heart. The circle is made by the right coronary artery and left circumflex artery, which runs in the atrioventricular circle, and it form a circle around the heart. The LAD and PDA in interventricular groove at the right angle from the circle, and this is the right coronary artery and left coronary artery, which runs into the AV sulcus and form a circle around the heart. LAD and PDA form a loop at the right angle to the circle formed by the RCA and left circumflex artery, and encircle the septum and provide blood supply to it. So the LAD runs in the anterior to the interventricular septum, and PDA runs into the posterior to the interventricular septum and provide blood supply to it. Origin of the posterior descending artery is expressed by the term dominance. So in majority of the individual, there is a right dominant coronary circulation, means the PDA arising from the right coronary artery. In around 10 to 15% of the individual, there is a left dominant coronary circulation, and this is more common in the male when compared to the female. In some individuals, there is a codominant coronary circulation, means the PDA arises from both RCA and LCA. Identification is very important in evaluating patient with the coronary artery disease and in planning for the CABG. Left main coronary artery, it extends from its origin in the left sinus of Valsalva to its bifurcation. Normally its length is 10 to 20 millimeter, but it may range from 0 to 40 millimeter. It courses between the pulmonary trunk and left atrial appendage and reach to the left AV groove. So this is a figure showing the course of the LMCA. Occasionally, the additional vessel originate from the LMCA and course parallel to the diagonal branches of the LAD, which is known as ramus intermedius. So this figure shows the trifurcation of the LMCA, in which the central one is a ramus intermedius, which is also known as the high diagonal or the first diagonal of the LAD. Rarely in 1% of the individual, the LMCA may be absent. In such case, the LAD and the circumflex artery originate directly from the aorta via separate ostia. This figure shows the right coronary artery ostia and the left coronary artery ostia. So if you compare The right coronary ostia is situated anteriorly and lower compared to the left coronary artery ostia, and that's why the air trapping is more common in the right coronary artery compared to the left side during the de-airing of the heart. Now we will see the left anterior descending artery. So it is basically continuation of the LMCA, and it runs along the anterior interventricular sulcus to the apex. In most cases it extends around the apex into the posterior IV sulcus, and it provides blood supply to the apex of the LV and the RV both. It supplies left ventricular free wall, the septum and the RV free wall, but it is only a small part of the RV. One or more branches to the RV connect with the infundibulum branches from the right coronary artery, and this coronary flow is known as the loop of the Vuissons. LAD gives off the septal arteries, which are 4 to 6 in number, and it runs almost perpendicular to the LAD, and this help for identifying the LAD in the angiography view. Virile number of the diagonal artery arises from the LAD and which course obliquely. This diagram shows the LAD, its branches and its course. So if we divide clinically, the LAD can be divided into three parts: proximal, mid and distal. The proximal part extends from the ostium to the first major septal perforator. The mid part between the first perforator and the diagonal 2, and the distal part is after the diagonal 2. If we look at the variation in the LAD, it is very infrequent. In about 4% it exists as two parallel vessels of about equal size. In some individual it may terminate before the apex. Now we will see the left circumflex coronary artery. It originates from the LMCA at around 90 degree, and it courses laterally into the atrioventricular sulcus. In its beginning part, it runs in front of the lower part of the left atrial appendage, where it gives off the atrial circumflex artery. In ventricular branches, it gives off the obtuse marginal artery, which supplies the obtuse margin of the heart. Why it is called obtuse margin? Because the angle between the left AV sulcus and the left margin of the heart is obtuse. In left dominant system, it gives rise to PDA at or usually before the crux. If we divide the circumflex artery like LAD, it has also three parts. In proximal part, it extends from the ostium to the first major OM, the mid part extends from the OM1 to OM2, and distal part is after OM till its end. Now looks at some variation. In some individual, the sinus node artery occasionally originates from the left circumflex artery. Rarely the left circumflex artery terminates before the obtuse marginal artery, and in some individual the number and the size of the obtuse margin are varying, and it is very common. Right coronary artery is a large coronary artery which extends from its right sinus of Valsalva, and it courses down to the right AV groove. In its proximal part, it gives branches like sinus node artery, conal artery, the anterior right atrial artery, and then it comes toward the right acute margin of the heart, and it gives branches to the right ventricular free wall. In region of the acute margin of the heart, it gives long branches named as the acute marginal artery, which courses toward the apex. RCA crosses the crux, where it takes a characteristic deep U-turn, and it gives up a AV nodal artery at the apex of the turn. RCA then terminates by bifurcating into the posterior descending artery and posterior lateral ventricular artery. The PDA descend in the posterior interventricular circus for a variable distance and give branches to the septum, to the right ventricle, inferior side of the right ventricle and the inferior portion of the left ventricle. Clinically, it is also divided into three parts: proximal, mid and distal. The proximal part is extend from the ostium to the first main RV branch. The mid part extend from the first RV branch to the acute marginal branch, and distal part ranges from the acute marginal to the crux of the heart. In the variation in the right coronary artery is very common compared to other artery. There may be a dual origin in the aortic sinus. In 10% of individual, it bifurcate within a few millimeter of the aortic ostium, forming two diverging trunk of the equal size. In some individual, the coronary artery has a separate origin from the aortic sinus and it is called third coronary artery. Acute marginal artery crosses the diaphragmatic surface of a right ventricle in 10 to 20% of the individuals. Now, let us see the coronary artery supply to the specialized area of the heart. Interventricular septum. The anterior part of the interventricular septum is mainly supplied by the 4 to 6 large septal branches arises from the LAD, which length is around 70 to 80 millimeter. The posterior part of the interventricular septum is supplied by the septal arteries from the PDA, which is around 15 millimeter of size, and so the majority of the interventricular septum is supplied by the LAD. SA node and AV node. In majority of the individual, the SA node and AV node are supplied by the right coronary artery, but in some individual it may supplied by the left circumflex artery. The AV nodal artery arises from the dominant coronary artery in majority of the individual, but in some individual it may arise from the left circumflex artery. The AV nodal artery also supply the bundle of His and the proximal few millimeters of the bundle branches. And the rest of the bundle branches and Purkinje fibers are supplied by the septal branches of the left anterior descending artery. An important accessory blood supply to the AV node is known as the Kugel artery, and this Kugel artery originates from the RCA or the left circumflex artery. The Kugel artery is present in around 40% of the normal heart. The papillary muscles have blood supply from the different coronary arteries. The anterolateral papillary muscle are supplied by the branches from the LAD, but may have supply from the circumflex artery. The posteromedial papillary muscle have supply either from the RCA or the LCX. Now let's see some basics for the standard angiographic view of the coronary arteries. So, for identifying the coronary angiographic view, there are some important anatomical landmarks which help us to identify the coronary angiographic view. So, the catheter in the descending aorta, the spine and the diaphragm are important anatomic landmarks, and rough rules is if the spine and the catheter is on the right side of the image, then it is a LAO view, and if the spine and the catheter on the left side of the image, then it is a RAO view. If these are spine and catheter is placed centrally, then likely it is a PA view. Same way, if the diaphragm shadow is present on the image, then it is likely a cranial view, and if it is not present, then it is a caudal view. So, how the nomination of this angiographic view is given? Basically, it depends on the position of the image intensifier when we do angiography of the patient. So, if the image intensifier is positioned right and anteriorly to the patient, then it will be a RAO view, and if the image intensifier is on the left and anterior portion of the patient, then it will be a LAO view. Same like when the image intensifier is toward the head of the patient, then it will be a cranial view, and if it lies on the towards the leg, then it will be a caudal view. Now, we will talk about some basic angiographic view for the left coronary artery. So, the first one is the RAO 30 and caudal 30, which is for the best visualization of the left main bifurcation and the proximal LAD and the circumflex artery. The knowledge of the orientation of the artery for given view can help identify the probable path of the artery in setting of the complete occlusion. In this image, we can see here the LAD is not visualized in the image. This is due to the total occlusion of the artery. So, in case of the RAO view, the LAD will be on the right side. So, and in case of the LAO, the LAD will be on the left side of the image. So, for easy remember, we can say LLL. In LAO view, LAD will be on the left side. These are the other views for the left coronary artery, which include the PA0 and cranial 30, which is for best visualization of the left main proximal and the mid LAD. And the another view is LAO 50 60 and cranial 30, which is for best visualization of the proximal and mid LAD and the distal circumflex artery. The LAO 50 and caudal 30 is known as spider view, which is for best visualization of the left main bifurcation and proximal LAD and the left circumflex artery. The PA0 and caudal 30 is for best visualization for the left main bifurcation and the proximal LAD and circumflex and obtuse margin arteries. If we talk about the angiographic view of the right coronary artery, the three views are very useful. The LAO 30, which is best for the visualization of the ostium and the proximal RCA. We can see here RCA is look like a C shape. In RAO 30 view, the RCA will look like a L shape, and it is for best visualization of the mid RCA and the PDA. The PA0 and cranial 30 is best for the visualization of the distal RCA and its bifurcation. Now, let's see coronary venous anatomy. So, coronary venous anatomy mainly includes three groups of the veins: coronary sinus, anterior cardiac vein, and Thebesian vein. Coronary sinus is the largest vein of the heart, which is around 3 to 5.5 cm in length. It is situated in the left posterior coronary sulcus. It is continuation of the great cardiac vein. It consists of two valves named valve of Wiesen's and the Thebesian valve. The tributaries of the coronary sinus include the great cardiac vein, middle cardiac vein, and the small cardiac vein. The great cardiac vein drains the same cardiac territory which is supplied by the left coronary artery, and the middle and the small cardiac vein drain the same cardiac territory which is supplied by the right coronary artery. The other tributaries of the coronary sinus include the oblique vein and the vein from the left ventricle. The anterior cardiac vein are 3 to 4 in number, which drains the anterior wall of the right ventricle. It opens directly into the RA. The right marginal vein frequently opens into the right atrium and can be considered in the same group of these cardiac veins. The Thebesian venous system drains the subendocardial, and it found throughout all four chambers of the heart, but they are more prominent on the right side of the heart. In addition, it drains the right appendage as well as a significant portion of the muscular ventricular septum. The Thebesian venous system provides the true shunt, and this is all about the coronary circulation, coronary venous system, and the angiographic view of the coronary artery circulation. Thank you.